All right, thank you. We'll move on to our next. So Manhal Siddiqi is a student from University of Buffalo. She did her undergraduate degree there as well in biomedical sciences and psychology. She has been exploring neurosurgery since the beginning of medical school and has been mentored by Dr. Levy and Dr. Siddiqui at Buffalo. She will be presenting to us today on factors associated with shunt-dependent hydrocephalus in aneurysmal subarachnoid hemorrhage.
Thank you for that introduction, Dr. Morgenstern. Just one moment. Perfect. Okay, I'm just going to share my screen. Okay. Sorry, I'm just having a little bit of a technical difficulty here. Can you see my screen? Yes, okay, perfect. All right, thank you again, Dr. Morgenstern, for that introduction. As mentioned, my name is Manhal. I'm one of the visiting sub-Is originally from Buffalo, and today I'm going to be presenting the results of our systematic review and meta-analysis on pre- and post-treatment factors associated with shunt-dependent hydrocephalus after aneurysmal subarachnoid hemorrhage. This was one of my independently led studies throughout my second and third year, and it was a very great experience from start to end. So just a couple quick disclosures from our attendings as follows. And then as a brief outline, I'm going to be going into the background a little bit on subarachnoid hemorrhage, the overall objective of our study, our methods and results, and a brief discussion of our findings. So just to set the stage, as we know, subarachnoid hemorrhage can be subdivided into traumatic versus non-traumatic. However, our study primarily focused on non-traumatic subarachnoid hemorrhages. As we know, subarachnoid hemorrhage is associated with a high mortality rate as well as a high long-term morbidity rate. Therefore, having an idea of what factors can lead to these long-term sequelae is an essential part of clinical management in these patients. The pathophysiology that we talk about with hydrocephalus and subarachnoid hemorrhage is that the presence of blood products can cause inflammation and scarring of the arachnoid villi, resulting in both obstructive and absorptive issues. This is likely secondary to the hemosiderin buildup and blood breakdown products. This combined with the decreased overall absorption in the granulations promotes the idea that this overall process is probably what leads to the development of shunt-dependent hydrocephalus. Hydrocephalus management, as we know, involves multiple strategies depending on the timing or length of presentation. Acute hydrocephalus is typically managed with EVDs. However, when this is not effective, we tend to switch to a more permanent version of CSF diversion in the subacute and chronic stages. Typically, we use VP shunts, but this approach is associated with its own set of potential complications. There was a study done in 2017 at Cornell and Columbia that showed from a 17,000 patient cohort, about 24% of patients developed at least one VP shunt complication within the first year, and 22% required a shunt revision at some point. These statistics just truly reinforce the need for careful monitoring and follow-up to minimize these complications and optimize outcomes. So for our objective, we found that in the literature, there are many various reports of risk factors associated with shunt dependency in these patients. However, the presentation has often been fragmented and heterogeneous. So our objective was to conduct a systematic review and meta-analysis to provide a more comprehensive analysis of these prognosticators and further build our knowledge base for clinical decision-making. So for our methods, we followed the standard PRISMA guidelines. We searched for studies in PubMed, Embase, and Medline. We looked at studies from inception to November 1st, 2022, and to ensure any accuracy, we had a two-party independent review and had a third party to resolve any discrepancies. For our inclusion criteria, we specifically defined shunt dependency as the presence of acute hydrocephalus that failed to resolve with temporary CSF diversion, or alternatively, hydrocephalus that developed in the subacute to chronic periods requiring shunting. We also limited our analysis to double-arm studies that compared these shunt-dependent patients to a distinct non-shunt dependency cohort. Initially, we identified about 1,700 articles. After we excluded ineligible articles, we secondarily assessed 70 for eligibility, and using our inclusion criteria, we selected 37 review studies for overall review. We used a meta-analysis for each collected variable and a fixed and random effects model, which was weighted for sample size for each study. And this was used to generate the estimated rates for each variable of interest. And just a quick look at our characteristics. We had about almost 13,000 patients over the 37 articles. We had 29 retrospective studies, 3 RCTs, and 5 prospective studies. We had a cohort of 2,200 patients with shunt dependency, and about 33% of these patients were male. So complementary to previous literature, we found that the variables on the left side of the screen were consistent with previous studies. Again, this had been noted amongst variable studies, but we found that the variables reported on the right were more fragmented. So we looked at high World Federation of Neurosurgeons score, granular vessel involvement, delayed cerebral ischemia, intracerebral hematoma, and decompressive hemicraniectomy. Over the next couple of slides, I'm just going to very briefly go over our results and a short discussion for each of these variables on the right. So for each variable, we've shown forest plots demonstrating the odds ratios. So starting off with the WFNS scale, for a score of 1 to 3, odds ratio is less than 1, and the significant interval did not cross over 1, which indicated that there was a statistically significantly lower likelihood that these patients will develop shunt dependency. In other words, a low WFNS score essentially was a protective factor. However, in contrast, a high WFNS score had a high odds ratio, or an odds ratio of 2.41, which indicated that these grades have a higher likelihood of shunt dependency. So the WFNS scale was introduced in 1988, about 2 decades after the Hunt-Hess score. However, contrary to Hunt, Hess, and Fisher, the WFNS score is based off of the GCS scale and the presence of focal deficits to determine the severity and predict outcomes of subarachnoid hemorrhage. In contrast, as we know, Hunt-Hess relies on clinical presentation, which is later translated into GCS, and then Fisher relies on radiographic presentation. So alongside establishing the significance of this scale, our study also corroborated the previous literature. However, subsequent studies have also shown that GCS-based scoring systems are superior to Hunt, Hess, and Fisher grades, given the objective way of defining the neurological condition. Every neurosurgeon is very well versed with GCS, and the inter and intra observer reliability is considered relatively strong. And then added to this was the element of focal deficits that made it a complete scale. So while the WFNS scale does have its own flaws necessitating modification, our study showed that it still may be stronger utilized as a potential marker in these patients who develop shunt dependency or are prone to develop shunt dependency. Next, we looked at aneurysm origin. Previous papers primarily focused on anterior versus posterior circulation aneurysms as their dividing factor for location, with posterior circulation consistently having higher odds given the tight anatomy. Our study was consistent with these previous studies. However, we also chose to analyze study that included a very granular breakdown of specific vessel involvement. We were able to further break down location to identify which vessels were at a higher risk, rather than just looking at anterior versus posterior. So what we found was that in both the anterior cerebral artery and the vertebrobasilar arteries, our odds ratios were greater than 1 and significant. In contrast, we found that the middle cerebral artery had an odds ratio of less than 1, indicating that there was a lower likelihood of developing this shunt dependency. We theorize here that this is likely based on which vessels are closer to which cisterns and how kind of the location of them is essentially what is more likely to be involved here. But overall, this kind of just reinforced the idea that granular vessel breakdown allows us to be proactive rather than reactive based on our knowledge of what specific vessels are involved. Next, we looked at decompressive craniectomy in patients who required an intraoperative decompressive hemicranie, and this was significant for an odds ratio of 3.36. Decompressive hemicranies are a well-established practice that lowers the elevated ICP in patients with a refractory increase in pressure following trauma or infarct. However, previous literature has noted that the evidence for aggressive surgical interventions is controversial in poor clinical grade patients. Our analysis did find that the likelihood of SCH or shunt dependency was higher in these patients. We theorize that, as we know, the removal of the skull dampens the normal vascular pulsatility in the Virchow-Robin space, which drives the bulk of our CSF flow. and this can result in a buildup of CSS and subsequent pressure. We hypothesize that this disruption of equilibrium is likely what interferes with the ependymal cell's ability to reestablish equilibrium. However, we did feel that we would need further, more basic science studies to try and confirm this theory. Next, we looked at delayed cerebral ischemia, again, significant with an odds ratio of 1.61. This is a critically preventable cause of poor neurological outcome and mortality, which affects about 30% of subarachnoid hemorrhage patients. A majority of the patients who develop DCI are left with significant motor deficits, cognitive dysfunction, and an overall reduced quality of life. DCI prevention has been the crux of many subarachnoid hemorrhage studies, but as of now, there are few treatment options available. Again, just reinforcing early recognition and detection being the key for timely intervention. And then finally, we looked at intracerebral hematoma. Again, had a odds ratio of 3.23, which was significant. Patients with additional post-op ICH are also described as being poor admission grade and historically also having unfavorable outcomes. Amongst the different literature, intracerebral hemorrhage secondary to subarachnoid hemorrhage varies from 4 to 43%. However, overall, the agreement is that this is a very negative prognostic factor associated with very high mortality rates greater than 80%. Again, this finding just reiterates the need for critical early recognition and detection and timely interventions. So as a systematic review, we did have some inherent limitations to our study. There is publication bias amongst these type of studies overall, especially because they're observational retrospective studies. As a result, we had very diverse patient populations amongst each study, and this resulted in a very heterogeneous representation of what risk factors were presented by each paper. As a result, we did have to exclude some variables that may have been very clinically significant, but were not statistically significant or analyzable. And we ended up cutting out some variables that were, again, very clinically significant, but we try to focus on having very granular data points to allow for more rigorous analysis, even at the cost of excluding related but unspecific data. For future directions, we kind of split it up into clinical impact and research impacts that we're hoping to make. Clinically, again, early detection, early recognition, and would allow us to help with improving communication and expectations to both patients and families, and managing expected lengths of stay and in-hospital protocols. In terms of research, we're actually trying to work on getting a buffalo population case series started with our subarachnoid hemorrhage population. Also, another idea that we were hoping to look at is looking at how these different risk factors play a part at different parts of this, our timeframes in hydrocephalus, in acute versus subacute versus chronic. This was just there was not enough granular data available for this. And then we're also hoping to go forward from here to build a model for shunt dependence, and then derive a simpler, more calculator-based tool based on our practice. Ideally, we would like to, at some point, externally validate this. We're working on getting this started with our med student team. And then at my last sub, I had a discussion with one of the attendings there about including a risk model calculator based on each prognosticator, which has been something that I've been thinking about and trying to get more input on. So these are just my references. And just really quickly, I want to acknowledge the team back in Buffalo, Dr. Levy, Dr. Siddiqi, Dr. Lim, who's been one of my mentors, and Dr. Montiero, as well as the rest of the endovascular research team. They've been a great set of support. And then I wanted to say a quick thank you to everybody here at Mount Sinai for hosting me this month and for allowing me to get to know your team and your service. I've had a fantastic time, and I'm really sad to be leaving this weekend. So thank you very much for your time. I'm open to questions.
Thanks a lot, Manhal. Great presentation. Obviously, this is a topic that is very pertinent to my practice. Were you able to look at spinal drainage or use of spinal drainage?
So there was 1 or 2 studies that did touch on it, but again, they were studies that just didn't have enough patients, or just we didn't have enough studies to do a proper analysis of it. So lumbar drainage was something we looked at. We even looked at clipping versus coiling to see if that had any impact, as like if treatment modality had any impact on our outcomes. There